So, good morning, everyone, and welcome to our session today. We are going for Thriving Neonate and Tertiary Center will be presented by Rawda Idris, my lovely friend. Rawda is ST3 Paediatric Trainee in Northern Ireland. Just joined last year. She's been in the UK for the last 4 years. Rawda is a mother of 2 lovely boys, and she was ex-associate professor in Sudan. She was teaching in one of the brilliant universities there, and she likes teaching, so she continued to teach here, the junior ones, and she's interested in cooking. Lovely to have you today, Rawda.
Thank you very much, Ilham, for this nice introduction. Good morning, everyone, and welcome again to one of the BSAP-CH workshops. I will share my slides with you. So today we are going to speak about your first job in a tertiary neonatal unit. Is my slides clear?
Yeah, I can see. If you
Yeah.
can make it bigger,
Yes.
please.
So, hi everyone. Before starting, I would like to listen from you guys. Where are you joining from? Are you from UK, outside UK? Which country are you joining us from? I can have some voices here. I would like this session to be interactive. I hear you and you listen for me, like, two-way. I don't want to spend all the time speaking to myself.
Hi there. I'm one of the clinical fellow working in Glasgow.
Hello, hi.
Hi there.
Amir.
Hi there. I'm about to start my GP training, and one of the first hospital rotation is pediatrics. So
Oh,
yeah,
yeah.
that's why I'm here.
Yeah, that's good. But are you going to work in a neonatal unit? Does it involve working in an
I really don't know. It's going to be a hospital
yeah.
rotation. They said pediatrics, maybe neonatology plus pediatrics.
Okay, yeah. So pediatrics is a special group. It's different. Sorry, neonates is a special group. It's different from the pediatrics group. So these are the small tiny babies, not the big monstrous babies.
Yep.
Sarah from North Wales, and we got someone from KSA. Who's that? I've just lost the name. So we got 2 others.
Yeah, good. So we are all UK based. There is nobody joining us from outside UK at the moment. Okay, let's crack on. So our lecture will be introduction to the new. This is the first lecture from a neonatal series. We're planning to do other more lecture for especially targeting pediatric trainees who are going to work, or any trainees who's going to work in a tertiary neonatal unit. So what is the objective today? I'm going to cover like a normal dynamic day in a tertiary neonatal unit in an NHS hospital, the environment and what you're expected to see there, skills and knowledge that you need to know, and then tips how to survive your duties and your night duties, of course. So let's start with a normal day in the NICU environment and what's expected. Can I ask you guys, have you been working in a NICU job before, in a tertiary unit, or even in a DHA hospital? Okay, so the neonatal unit, there are 3 levels of neonatal unit. We have, in tertiary hospital, we have 3 units. The NICU, that's the neonatal intensive care unit, which is level 3 unit. We have the high dependency unit, which is level 2 unit, and we have a special care baby unit, which is level 1. In addition to these units, we have the postnatal ward, the delivery suite, and some units will have surgical and cardiac and NICU units. So what are the difference between these 3 levels? So the level 3 unit is the unit where we accept the extreme preterm. Any baby less than 32 weeks should be admitted to a NICU unit, especially if the baby has extreme low birth weight, have congenital abnormalities, baby or extremely preterm babies less than 38, 34 weeks. These are babies who really need to be admitted to level 3 NICU. Babies with congenital abnormalities who's advised to be born in a tertiary unit where there is facilities to manage the baby immediately. HD unit is the level 2 unit where the baby who has been stabilized but still need ongoing care, ongoing respiratory support, ongoing TPNs. So these are the babies who will be admitted in HDU. And then stepping down is the special care baby unit. These are babies who are really stable, maybe needing a little bit of respiratory support, a little bit of CPAP or a little bit of high flow oxygen, feeding on their own on NG tube, feeding some antibiotic, but not that, major infection or drugs that need follow-up or need special precaution. So these are babies who are being prepared to go home. And of course, the postnatal ward is where the bulk of the work will be for most of the pediatrics, and especially the GB trainees. You'll see a lot of postnatal babies. And then the delivery suite, that is a unit shared between the obstetric team and the neonatal team, because you will be called to high-risk deliveries, emergency C-section, elective C-section with special red flags on it. And the surgical and the cardiac intensive care unit, they are not available in each tertiary unit. In specific units, for example, where I work, there is no surgical and cardiac NICU. And another point, I want to make a difference between a tertiary unit and a DGH hospital. So in a DGH hospital, it's usually a SCIBU or sometimes a high dependency unit. There is no NICU units in there. Intensive care NICU units where you provide ventilation, ventilatory support, or other kind of medical support. Okay, so who is your team in the neonatal unit? The team is really big. I would like to emphasize that NICU is all about teamwork, the multidisciplinary team in the unit. So the doctors, your consultant, your regs, your colleagues, your SHOs, and then doctors for other departments, the surgical departments, the cardiac departments, renal departments, metabolic, genetic. These are all doctors involved in the care of these sick babies. And then the AMPs, they are superheroes. Every one of here is a superhero in the NICU. The nursing staff, they are great. If every nurse, she's taking care of her baby in a very delicate and very high-skilled way. Nurses are really the bone back of the NICU unit. Like a junior doctor, if you're stuck, ask one of the nurses. They have a lot of experience. And then you have your healthcare assistant who help with all other things around the unit. The pharmacist, superstars, the nutrition, the superstars too, occupational health team, physiotherapist, they are heroes, SALT team, ophthalmology team who take care of the ROP. The midwives are one of the important parts of the team when going down to the delivery suite. Breastfeeding coordinators, superheroes too. They are very helpful in the postnatal ward when you have a baby who's not feeding well or a first-time mom who can't breastfeed her child, who needs support. So these are the heroes there. The lab people, lab technician, the imaging center, and the housekeeping team who keeps the place tidy and clean after our mess. So these are superheroes. So please pay attention to all of these. When I first started my job in NICU, there was a lot of people around me. I didn't know who are they, but eventually I discovered every one of them has his own part. Everyone has his own knowledge. So you're not alone there. You have to ask other people. Go to your pharmacist about the drugs. Go to your nutritionist about the feeding. A baby with disability, go to occupational health therapist. So these are all important part of the team. Okay, so how is the daily dynamic in NICU? So your day will start by handover between the doctors and nursing staff, and the transport team is part, I forget to mention them. The transport team is the doctors, part of the doctors teams, part of the NICU regs or nurses who will transport babies from and to the unit, transporting out and maybe transporting baby into the unit. So we start the day with the handover. We review all the babies quickly, what's happened, what's the new event, serious event, happening during the night, any change of ventilator, any baby collapsing. So we go through each and every baby individually in a very concise and quick way. And then, NICU team will hand to the NICU team, HD, and the night team will hand to HDU alone, and a hand to the SCIBU team, and then the SHO night will hand to the postnatal team in the morning. You need to log into your bleep. It's very important. Don't forget to log in your bleeps or take your bleeps with you, because you need to be reachable at any point of the day. Hand washing and ANTT, that's aseptic non-touch technique. Don't forget, hand washing is very important because you are dealing with a very sick baby. Most of the babies in NICU, especially NICU, are very sick babies. You need to hand wash very good. And then we start with pre-round preparation. You go, if you are allocated to NICU, HDU, or SCIBU, you go, you prepare your notes for the ward round. You review. We'll have, I will speak in a coming slide about what you need to do for your ward round. You review your notes, see what happened during the night, what's new, and you present it in the ward round. Then we have the Badger notes. We daily input in the Badger, and the Badger is a system where it's involved. It's a UK database system for neonatal units, where every day the baby's information will be put. So there will be a big pool of information about NICUs in UK. It's a very important part of the daily rounds. Then during the rounds, you review your fluid requirement, feeding, in input and output balances, your blood result, X-ray, communication with other part of the MDT team, then your job list, what should you do through the day, blood results, chasing or taking some bloods, X-ray, cranial ultrasound, lung ultrasound, blood gases, prescribing your fluids, antibiotics, and TBN, preparing discharge letters and transfer letters, attending delivery and C-section. And then there is a whole lot of postnatal ward jobs when you're called to review babies for a lot of things, or a baby with an antenatal plan that need to be prepared or need to be done after delivery. So it's really a busy unit. It's really, really busy unit. You have to be prepared to the day. Sometimes it's non-stop. Okay. And so what do we have for our word round? What we do, what are the most important things? So when we do our word rounds, most importantly, you have to document the day of life of this baby. How old is the baby today? Is 2 days, 3 days? What was his gestational age? And what is the corrected gestational age? So corrected, for example, if a baby is born at 32 plus 1, okay? If he is 5 days today, so his corrected gestational age will be 32 plus 5. And whenever you finish 7 days, you add another week. So this is the corrected gestational age. Okay, it's especially very important in preterm babies. And we do correction for the gestational age up until 2 years in extremely preterm babies. And then in your notes, you have to review and note the background of this baby. What is the background? Is he a preterm? Is he an outcome of an emergency C-section? What happened during delivery? So these are very important bits and pieces of information during your notes when you're taking the ward round notes. And then what are the ongoing problems today? What is issues today? Because you need to solve each issue on daily basis. And what happened overnight for this little baby? And then you see the ventilation. Is the baby needing respiratory support? Is he on ventilator, or is he just on room air? What's the mood and for how long he has been ventilated? Did he need surfactant? What is the recent blood gases, and what's your recent chest X-ray? Because all of these determine if we need to go on more ventilation, to continue ventilation, or this baby today we will extubate the baby, or we need to step up his ventilation. So this is very important. And then cardiovascular, you have to know, especially in preterm babies, is the baby hypotension? What's the blood pressure? And is there any requirement for inotropes? Does the baby have PDA? Did he need treatment for his PDA? Is it a significant one? Did he need treatment for how many courses of treatment did he need? CNS is very important. These are four major morbidities and mortalities for the baby. So abnormal finding, seizures, abnormal tone, abnormal movement, result of head scans, and then feeding and fluid. How many mils per day is the baby taking? Do we need to go up on our fluids, or do we need to restrict the baby? These are all very important daily notes we need to take care of. And then is he a baby, is he on TPN lipids or express breastfeeding plus breast milk fortifier? Is he oral or tube fed any part of the day? Is he or is he a sick baby that we're not giving anything orally? And we need to take care of fluid balances in our sick babies and very premature babies, and then reviewing our blood results, sodium, potassium, and a lot of things. And then the infection status of this baby. Does this baby have sepsis? Is he on antibiotic? What are the results of the culture? Did we need to do a urine screen? Did we need to do a lumbar puncture? What did we need to do, and the results of these? And of course, medication. What is the antibiotics? What are the doses? When you work in NICU, there will be kinds of medication that you will know every day, like caffeine is very important for preterm babies because caffeine is a respiratory stimulant. So most of the extreme preterm baby will be on caffeine because this help them breathe. And then your lines, what lines is in this baby? Does he has just a peripheral line? A baby with a peripheral line, that means a stable baby, or this baby needs a central line, umbilicus venous line, or umbilical arterial line, or a PICC line, or Broviac, or so this is very important to take care because lines themselves are causes of bacterial entrance sepsis. For example, again, if there is other teams involved in the care of the baby, you have to review the notes of other team. If the baby is a cardiac baby, what did the cardiology team come and said? Do we need to start prostin? At what level do we need to start? Are we weaning? Are we going up? So these are very important. This is the importance of the other part of the team sharing the care of you. You have to look at their notes. And by the end of the round, you have a plan for today, what you need to do. Ventilation-wise, fluid-wise, blood investigation, line-wise, chase any result, call any other part of your MDT for advice, for care, for transfer. So it's really a busy day, and it's really, really, you have to be focused on your rounds. And then I would like to speak about, is my screen, can you see my screen, guys?
Yes,
Yeah.
we can, Rawda.
Yeah. Okay. Then what equipments do we use in NICU? Can I ask, I want to listen from you guys. What are you doing in your NICU days?
We got few guys from NICU here.
Yeah, I would like to listen to them. Hello, everyone. Did we have our coffee and teas with us?
You can open up your mic, guys,
Yeah.
please.
Okay. Equipments in NICUs. When you come into NICU the first time, it's really a big world, and you feel very small among these all devices beeping, alarming here and there, and you don't know what is it, because I have been there. It's a scary place at the beginning, but when you know what are you dealing with, who is your team, what is your equipment, what are you going to do, what things you need to know, it will be an easy task, and actually you'll enjoy it because I'm enjoying it now. So let's start. We have resuscitators. We have different types of resuscitator. It's very important to know what type of resuscitator you are working on in your unit. So for example, in Belfast Trust, we have some certain types of resuscitator. We have the Banda resuscitator, we have the Pfizer and Pikel resuscitators. You need to know, how do you work with them? How do you put them on? How to put them off? You need to know if something happened, if it's not working, who is your technician to call, because they are very important pieces, devices in your work. And then you have the new puff. And I think if you are working here in UK, you know the new puff. That's the piece where you develop your PEEP and PEEP. And you have to make sure that you're using the correct face mask. We have different sizes of our face masks. And then you have to make sure that your suction is working. You need your hats and towels for the baby, and warm towels, don't forget them. Of course, the incubators in the units themselves, the ventilators, there are a lot of types of ventilators. They're really confusing, but still you need to know your own ventilators in the unit. Sometimes there will be like, handover guidelines. You need to know your guidelines in the unit. So we have the conventional ventilation, the BRVCs, the high frequency oscillating ventilators. We have the ECMO. We don't have ECMO in our unit. This will be in a very specialized unit. We have the NIV-NAVA and the CPAP, the high flow, the RPAP, which is used for the extreme preterm babies. So the NIV-NAVA and the CPAP and the high flow and the RPAP, these are non-invasive modes of ventilation, but the conventional ventilation where you need to tube the baby and use the ventilators. And then you have the CFAM. This is the cerebral function analysis monitoring, is used for the baby who is subjected to HIE. That means hypoxic ischemic encephalopathies. You have your intubation kit. You need to know, this is very important, you need to know your trolleys, your intubation trolley. You will have the airway and breathing, and then you will have the vascular access. So you need to know where are things, where can you get your things, your tubes, the sizes of tubes, which sizes is appropriate for which babies. Every unit has its own guidelines for intubation. We have our own guideline, even for the plaster, how you cup the plaster, how you put the plasters. So you have to know your own guidelines in your own unit. And before you go to work in a unit, ask about the guidelines, have a look before going there. Chest drains for pneumothorax babies, drugs is very important. Every unit will have its own printed manual agreed from the unit, from the consultant and from the pharmacist. These are the drugs we're going to use. We're going to use them in this dose and this interval, and we need to do follow-up bloods in this way. So you have to know all of that. Lines, you have to know the peripheral, where can you get the peripheral lines, the central lines, how can you prepare for them, what's important, where can you get the missing bits and pieces. Again, every unit has its own guidelines for doing the central lines. Then you have to know your contraindication, your complication, and determining the position by doing x-rays, chest and abdominal x-rays, and how to deal with them. This is a very important part in as a doctor working in NICU. And then your feeding tubes and your ultrasound machines and a lot of other equipments. Maybe I just missed them, but it's a really, really big place with a lot of machines and a lot of procedures. Let's see. Procedure-wise. So if we have sick babies, if we have equipments, we have a lot of procedures. So intubation, ventilation. As an SHO, pediatric SHO, or a pediatric trainee working in a neonatal unit, you need to have your choice for intubation, putting a UVC, putting a UAC, doing bag and mask ventilation. So these are all procedures you have to take in. And as you go on your training, there is a lot of procedure you need to do. So let's see, what do we do in NICU unit? We do intubation ventilation. We do surfactant administration, either through a tube or either through less invasive administration, which is called LISA, where we use a LISA catheter. That means a small catheter, not a tube. We have the central lines, umbilical venous line and the umbilical arterial line. We have our peripheral lines, our PICC lines. These are all found in the guidelines for each unit. We have blood sampling, peripheral blood sampling, and central lines. We have blood transfusion, heel pricks, lumbar puncture, urinary catheter, blood culture under aseptic condition. And this is very, very important because you are treating a sick baby when you are suspecting sepsis it should be done under aseptic condition, because you don't want, skin commensal coming and starting unnecessary antibiotic or starting a prolonged course of antibiotics. You have to be very careful in this part. And then your chest drains for pneumothoraxes, X-rays, ROB checks, cranial ultrasound, lung ultrasound, echoes. These will be done by senior colleagues. But as an SHO, also you need to know how to do a cranial ultrasound, and some unit will do lung ultrasound. And we have been doing lung ultrasounds in our unit. Your phototherapy machines, triple light, double light, single light. You have to know all about these things. And there's a lot of other procedures you will be doing. So this is not an exclusive list. It's just a list listing out what to anticipate, what procedure. It's very difficult to speak individual about each procedure. It will take time. So again, my advice, if you are working in your unit, go and have a look at your procedure chapter, procedure section, and know what you need to do, and maybe take screenshot. What I do, I take screenshot, for example, from intubation, keep it there. When we need to intubate a baby, quickly, there's there, I know. It's really difficult to memorize everything. I don't have a good memory, but maybe you do, guys. It's really difficult to remember everything. So you need to have your backup. Make sure that you have your guideline on your phone, or you screenshot the things you feel that you need to be, you need to memorize yourself about them. This is very important to have your backup plan, and backup plan it's for yourself. You can do it for yourself. I mean, it's something that, I need to keep this for myself here. Maybe I know this, I don't need it, but this one I need it in my phone. I need it very close to me. One thing, guys, I want to emphasize about hand washing technique with soap and water. It's very, very important. We have 12 steps here, but there are major 7 steps for hand washing. You use wet your hand, use your soap. Make sure you rub your hands very well. Rub the palms, rub the back of your hand, inside your hand, your fingers, your thumb, your wrist, and then wash it all together and dry, and then gel your hands. And that's important, especially for every procedure you're going to do. If you're going to do a blood culture, if you're going to do lumbar puncture, whatever procedure. If you're going to do a cannula, sometimes not important. If you need to wash your hand when you enter the unit, that's our policy. I know some units is a non-wash. They don't have water inside, the water is outside, but again, you need to wash your hands before entering the unit, and then gelling your hand wherever you go to an incubator and come out of an incubator. Gelling your hand whenever you're doing, if you're doing an ultrasound, cranial ultrasound, make sure you wash your hand and gel it, and before going to an incubator and after getting out from the incubator, and clean your device. This is very important to be a clean space for babies, because remember, these are very vulnerable babies. Okay, one important thing, please don't forget to communicate with the parent from the beginning, from the start. You have to involve the parents. You have to involve them in when, for example, preterm babies. You have to communicate with the mother, counsel the mother about the outcome, what is anticipated in the care of this baby, what can we do, what can we not do, and what is the hope of the mother, what is she thinking that we can do, what is missing. And especially in preterm babies, you have to speak about breast milk, colostrum. Is mommy have to breastfeed if she wants to breastfeed, and to speak about the benefit of breastfeeding. And again, in every sick baby, you need to communicate with the parents. What's happening? What are we doing? And what are they anticipating? We have been facing a lot of, communication issues, because baby has been sick, and parents didn't know overnight that the parent's sick, and then they just come and found that the baby is intubated or something happening. They will be shocked. They will be stressed. They will be worried. So you have to understand that. You have to be gentle. You have to be sympathetic. You have to give them chance to express themselves and express their frustration and anger and their question, what they want to know. Is it from you, or from the surgical team, or the cardiac team, or any other part of your team? So please give them time. Before going to skills, I would like to listen to your experience about your NICU. Is it this more or less the same? What do you do in your NICU units? Is anyone here to speak today?
Ahmed is working, so he's not able to open his mic.
Okay. Okay. As a doctor going to work in a tertiary unit, there are skills and knowledge that you really need to know to prepare yourself for this work. Let's see what we need to know. So the first thing you will be doing as a neonatal doctor is attending delivery. That's the first part when the baby come out to the world. So attending delivery, it's very important, guys, that you do your neonatal life support, the NLS course. It's a must. Even if you are working and you couldn't do it before starting your neonatal shift, you need to do it at any point during your shift or even after, because you will be, as a pediatrician, you will be dealing with neonate all the time. So it's very important. And you need to know that the NLS algorithm has its part for a term baby and a preterm baby. You must know that, because approaching each type of term or preterm delivery is a little bit different. So first things first, when you go to delivery, who do you need with you? Is it like, is it just, there are sometimes, for example, where we work, they will say category 1, category 2, category 3. What type of category that means? Is it safe to go by yourself, or do you need to call your reg with you? Do you need your NICU nurse or consultant? And of course, these are the extreme preterm babies, but the term baby, you can go by yourself if there is no problems. And the midwives are really good. They will tell you from the beginning, oh, this is like category 3 C-section. Can you please come? They will tell you the gestation age of the baby, if there is an abnormal CTGs, bradycardia, prolonged bradycardia. They will give you a heads up so you can prepare and speak to your reg. If you are confused about, should I take my reg or should I go alone, go and speak to the reg. This is this and this and this. I'm confident to go down, or I'm not confident, I would like you to come with me. So you have to know who's going with you. And if it's an extreme preterm baby, any babies born less than 32, or as an SHO, you need your reg with you. And any baby born less than 38 weeks, of course, NICU nurse consultant is very important. And when you go down, role assignment is really important. So the reg will be dealing with airway, you will be dealing with chest, listening to the chest. Someone will be dealing with taking care of, your oxygen. Someone will take care of your suction. So it's very important in a very complicated delivery to know your role assignment. Okay, another very important thing, check your equipment, guys. Please don't forget to check your resuscitator, and I will speak about that in the next coming slide. And don't forget, when you go down for a delivery, is it a term or a preterm baby? Okay. If it's term baby, is there abnormal CTG? Is there bradycardias? Is there a chance of asphyxia? If it's a preterm baby, what's the gestational age? And is there any other abnormalities you need to know? And your obstetric team is very part of your team, the midwife and the doctors and the obstetrician. Gather your history, please, from them. Estimated what's the gestational age and the estimated birth weight for this baby, especially in preterm babies. Ask about your risk factors for early onset neonatal sepsis and use your KP calculator. You can start to use even before the baby is not born. And then preterm delivery, ask about antenatal optimization and emphasize on delayed cord clamping and normothermy. And I will be speaking about all of these bits and pieces. Again, very important in a preterm delivery or even a term baby, thermal care. Make sure your resuscitator is heat on the maximum. You need your hats and towels, okay? And the poly bag for a preterm baby. And you have to make sure that the room temperature is something between 23 and 25. And especially in less than 28 gestation age, the temperature should be more than 25. This is the temperature control. So you're controlling the environment, the whole environment, and you're controlling your resuscitator heat. When the baby is born, hit the clock immediately. It's very important. Every second is very important in the life of this baby, especially if the baby is sick. Okay, don't forget to hit the clock. And then you need to know again your NLS algorithm. You need to know your APGAR scoring at 1 minute, 5 minutes, and 10 minutes because it determines a lot of things. You need to think about cord blood gases. Do I need to take cord blood gases? Because sometimes the obstetric team will look at you, the pediatrician will ask you, do you need cord blood gases? You have to have a clear answer for this question. So a baby who is having abnormal CTG, bradycardias, any abnormal event, yes, I need cord gases, please. Okay. And then don't forget to document your resuscitation by second, by minute and second. Okay. It's very important. So when you go back and see what happened, so we understand what went wrong. Is it something that a mistake has been done or something that cannot be avoided? So this is very important. Okay, let's go to let's go to the part of where we check our equipment. So guys, as I told you, resuscitators, this is I think this is a Banda resuscitator. We have something like this in our unit. It has a overhead heater. It has a monitor there where you can see your peeps and numbers. It has a suction part and it has a new puff installed in it. Sometimes there are some resuscitators that has a new puff outside of it. So first things first, as we said, radiant heater on full. Make sure that the resuscitator is on. When you go to delivery, the midwives kindly and lovely, they will be putting the resuscitator on, but you have to make sure because there's bits and pieces that you, as a neonatal doctor, make sure your pressures, your things are all within the accurate numbers. So heat on first, maximum please, especially if it's a preterm baby. And you will have drawers down there. You will have your poly bags, your hats, and the towels will be brought to you by the midwives if you want, dry, warm towels, because you don't use the wet towels forever. So breathing support, your new puff, you have to make sure that your new puff is at 8 liters per minute. And for a preterm baby, use your RPAP. Sorry, maybe I didn't explain what's an RPAP. So an RPAP is a new system, a revolutionary new system that use humidified warm gas for preterm babies, because your new puff, it's immediate, but your gas will be cold. The RPAP needs to be prepared. If you have a preterm delivery, you need to call your technician to prepare your RPAP. It takes 15 minutes until it works properly and provides you the warm and humidified gas. And you need to make sure that's on 10 liters per minute. Pressure support is very important, guys. So if you have a baby who is more than 32 weeks, your PEEP needs to be 30, your PIP needs to be 5, and your FiO2 starting point is 21%. As your gestational age goes down, your pressure goes down, your FiO2 goes up. So for example, 28 to 32 weeker, your PIP here will be 25 because you're using very gentle pressures, because these babies has very vulnerable lungs and their lungs are very compliant. You don't want to rupture them. You use your PIP 5 and you start with an FiO2 21 to 30. You titrate as you go on because you're putting your pulse oximetry on these babies. And then for the extreme low birth, extreme preterm babies, you start with a PIP of 25, PIP of 5, but you start with an FiO2 of 30. But you have to make sure that you're using your oxygen judiciously, because you don't want to use 100% oxygen. Of course, we know the complication in using high levels of oxygen about retinopathy of prematurity. You have to make sure that you're using appropriate size face mask, because you need to have a good seal when you're using your new puff to deliver your inflation and ventilation breath. Also, you have to make sure that, again, appropriate RPAP nasal mask and CPAP hat. And then if you have adverse event, bradycardia, or this is a preterm baby who's having bradycardia or abnormal CTGs or anything, you have to be always prepared to prepare your airway trolley. Because of that, I'm saying to you, know your airway trolley, know your intubation kit, the T-tube, the length of the T-tube. Are you going orally? Are you going nasally? What do you need to go orally? What do you need to go nasally? Your plaster should be ready. Everything should be ready. Put in mind, sometimes you might need to do emergency central venous access. So also know your things. Also be prepared sometimes that you might need surfactant. So be prepared. So it's very important to know your kit. Where is it? Where can I find my things? Where is the storage? If something is missing from the trolley, where can I get it from? For example, if we are going to have a preterm delivery, you go earlier, prepare your trolley, or even know your things. And if you want to prepare things, prepare them, put them there and cover them, and put out your surfactant, your laser catheter. Everything should be there. We're not going to wait until the baby's out and then, panic and searching for things. So be organized and anticipate your things, your problems. Okay, I just want to go quickly through the APGAR score system and the NLS. It's a very big topic, the NLS. It's not the right place to talk about it here. It's a course by itself, a 1 day long course. It's very useful course. It's a systematic approach to the baby, what you need to do. You start by stimulating the baby first, and then if the baby doesn't, breathe by himself, you start by providing 5 inflation breath, 1 person not working. And how do you know it's not working? It's your heart rate not going up. The baby's not breathing by itself. The baby's, floppy, not having good tone and poor color. You do a 2-person technique or suction, or use your airways. And if you're still not getting anything, and if you're getting your if you're not getting anything, then at this time you should consider about tubing the baby, intubation. At this time you should have a senior with you. And if you manage to do a chest lift and your heart is not coming up, you need to think about chest compression. You need to think about your drugs. So I advise you, every doctor who needs to work with babies need to book himself the NLS course. And it's a course that will be done every 3 years. So make sure that your course is up to date. And make sure we have 2 small parts in this algorithm. We have the preterm babies. Okay, if you can see here on the screen, it says the preterm baby less than 32 weeks. What do you need to do? You place the baby in a plastic wrap under the radiant heater. Okay, the inspired oxygen that's what we have been saying. 28 to 31 week, you start with 21 to 30. Less than 28 week, you start with 30, and your inflation breath, you start with a pressure of 25, and you have acceptable reductal oxygen that guides you to about, do you need to go up on your FiO2 or do you need to go down? So it's a really very good algorithm helping you. And then for the APGAR scoring, it's very important. APGAR, what does it stand for? So A, activity, P, pulse, that's the heart rate, G, it's the grimace that reflects irritability. That means, is the baby responding to you when you do a suction or when you're trying to stimulate the baby? The appearance of the baby, is the baby blue, pale, pink body, blue extremities, or totally pink? So you are grading each part of this scoring system. And then respiration, is the baby breathing by himself? It's regular or regular. It's a vigorous cry. Definitely this baby is breathing. So whenever you see activity absent, that's 0 point. Flexed arm and legs, that's 1 point. Active babies who's fighting you, who's crying and vigorous, that's 2, and that's the full score. So if you look at this, these are 5, and we have the maximum 10. So if the baby is scoring 2 in each category, so he will score 10. So 10 is the maximum. Okay, but any lower scores, less than 5, that's not good. Okay, and you assess the baby in 1 minute, 2 minutes, 5 minutes, 9 minutes, 10 minutes, according you assess the baby. But basically it's 0, 5, and 10 minutes. You need to know your APGAR score. Okay. Then we can go to speak about two important things in delivery when you go to delivery, the preterm delivery. I would like to ask you guys, do anyone know about prenatal optimization? Doctors who has been working with preterm babies and attending preterm deliveries?
Sorry, what's the question?
Doctors who working with preterm babies, do you know about prenatal optimization?
There is some people in the chat. Can you open your mic, please, guys?
Yeah.
Yes, I do.
Mhm.
In Gabon, it's called the Periprem passport, I think, where the care for the preterm infant starts from the antenatal, from the obs and gynae end, where you ensure that the mom has gotten the antenatal steroids, magnesium sulfate, and all the works, and then down to when the neonatal team is ready, that the baby is coming, and of course, like you said, the theater is prepared and all that you need, the poly bag, and ensuring the servo control, that the temperature in the room is optimal, like you said, plus that you receive the baby in the poly bag and you do not transfer the baby until your temperatures are fine. And then you can attempt skin to skin before you leave the theater to the NICU. I mean, that's the only way I could put
Yeah,
it
good,
in.
Mama. Thank you very much. Yes. Actually, yes. Prenatal optimization, that means you are optimizing the chance of this baby to live. You are giving the maximum chance for this baby to survive without complication. So exactly, it starts from when the baby is in the womb until you receive the baby. So yes, good, Mama. So preterm delivery, prematurity is the biggest cause of morbidity and mortality under 5. So if we want to maximize the chances of this baby, there is an evidence-based approach to do that. So the British Association for Prenatal Medicine advocates for prenatal optimization pathway. So what is it? It's delivering an evidence-based intervention in the antenatal, intrapartum, and neonatal postpartum period to improve preterm outcome. So let's have a look at this diagram. We can see 3 big blue circles and then small purple circles. And please, always look at the bottom. Counseling of the parent and shared decision making is very important. Okay, let's see, what do we have? Start by the left side of the diagram. So prediction of preterm birth. What does that mean? It's when a lady comes, when she's the preterm gestation, you take detailed history, anticipating if the mom is in delivery, what's the complication, what's the causes of this delivery. And then there is something called fetal fibronectin. This part is part of the obstetrical team job, but we need to know about it. Fetal fibronectin is a substance that's produced by the fetal that give you anticipation that this fetal will be delivered soon. And the cervical link, of course, cervical effacement, that means the lady is really in delivery, okay? And then we have the antenatal optimization part that we need to be involved and know about. Place of birth. If we have a preterm baby in a DGH hospital, for example, a 25-weeker lady, you will transfer this baby to a tertiary unit where the baby will have the highest chances to survive, because you have your ventilators, you have your neonatal consultant, you have your neonatal neonatal nurse, you have your units there. So what you do, it's in neutral transfer from a DGS. You will be working in a DHS pediatrician, and you'll be working at a NICU unit as a pediatrician too. So you will be sending and receiving this baby at one point. So antenatal steroids, and when we know what's the benefit of these, magnesium sulfate, and antibiotic. I'll speak about this on the coming slide. And then peripartum optimization, that means when the baby is out there. If you see, these are things that have been done before the baby came out. And then the baby is out now. So optimal cord management, umbilical cord management, normothermia, and maternal breast milk. It's a very simplistic approach if you can memorize it. And it will be at the back of your mind. And whenever you will be a doctor in the neonatal unit and a colleague from the DGH is sending an in utero transfer, you need to know, did the mom have steroids? Okay, magnesium, antibiotics, because if she didn't have and she's coming here, you need to know how many courses she had and are you going to give it and when it was given. Okay, so let's just speak about the details of this, the previous diagram. So if you look here, the antenatal optimization care bundle, what are the key elements here? You have a blue graph at the top and at your right side. So accurate predilection of preterm delivery and the need for preterm birth. That means your mom, this mom is really going to deliver this baby. Detailed history, this is done by the obstetric team. Fetal fibronectin and cervical length and placental growth factors. So this is the job of the obstetric team. They will tell you, this lady, she's going to deliver this baby, okay? And the other part of the blue bar is optimizing the place of birth of this baby. In utero transfer to NICU. Sometimes some babies are unfortunate. They will be delivered, but eventually they will be transferred. But in utero transfer is the best for the baby. So what babies need in utero transfer? Babies, single pregnancy, less than 27 weeks, or multiple pregnancies, twins or triplet, less than 28 weeks, or a very extreme low birth weight baby who is less than 800 grams. So all of these babies should be in utero transfer. That means if you're working at the DGH and this lady came and, you know, the obstetric team called you, this baby shouldn't be delivered here. You should go to a tertiary unit. Okay, so accurate prediction of preterm and optimization the place of this birth. Okay, what should we do? What should be done? So we have 3 interventions. We'll give steroid, we'll give magnesium, and we'll give antibiotic. So steroid, when do we give steroids? Any pregnancy less than 34 weeks. When do we give them? Anytime between 24 hours and less than 7 days. This is the efficacy period for the steroids. I mean, if you have a mom who's coming in a threatened, like labor, she's laboring early, and then she had her steroid and she's fine. Let's say she's 25 weaker. She had her steroids and she's fine. And then she presented again at 28, 27. Again, you will give the steroid because this is the period of the efficacy. And then you still can give it under 24 hours. You still can give it. Whenever the mom comes and we're anticipating that she will deliver, we will give the steroids. Magnesium sulfate, any pregnancy less than 30 weeks, and also we will consider it from 30 up to 33 plus 6, will be given magnesium sulfate. So it's more than 4 hours and less than 24 hours. And again, less than 40 hours is beneficial, okay? And then antibiotic, any preterm labor or you are suspected pre-prom, prolonged rupture of membrane or SROM in any preterm baby. So antibiotics will be given immediately. So let's see the benefits of these things. Why are we giving all of these things? So steroids, what's the benefit of this steroid? So the benefit of steroid, it would reduce your death and would reduce your necrotizing enterocolitis and reduce severe interventricular hemorrhage in extreme preterm babies. And you have the percentages here. The steroids are one of the drugs that have been used for the longest time for preterm babies. Magnesium sulfates, what do? They reduce cerebral palsy by 30%, okay? Antibiotics, why are we giving antibiotics? The risk of death from GBS in preterm infant is 25%. This is very high, and it's 10 times more of term infants. So any mom, even if she's term, presenting with pre-prom or prolonged rupture of membranes, we will give antibiotics. And of course, we have a definition of prolonged rupture membranes in a term and a preterm. In a term baby, it's anything above 24 hours. In a preterm, it's anything about 18 hours. And place of birth, of course, if not born in a tertiary unit, there is up to 3-fold higher risk of severe interventricular hemorrhage and periventricular hemorrhage, and again 1.3-fold of higher risk of death. So this is very important, guys, the antenatal optimization pathway. Let's go to the other part of it, optimal cord management. What does that mean, actually, optimal cord management? It's any baby less than 34-week gestation. We will do delayed cord clamping. What does that mean? That means when the baby is delivered, we'll keep the baby attached to the placenta by the cord for at least 60 seconds before clamping the cord. Why do we do that? Optimal cord management reduces the deaths in preterm baby by nearly the third. Okay, and the numbers of baby needing to receive optimal cord management preventing this is around 50% of all babies, as low as 20% in mature babies. That means in preterm baby is very important. Reducing the risk is more. So what happened actually in life? So, you know, conditions are favorable. You're not thinking about this baby will need immediate resuscitation. I mean, there is no abnormal CTG, there is no prolonged bradycardia, and you can give the baby chance, especially if the baby is born. What happened in actual life? The baby will be born. Your midwife will put her hand on the heart, see if there is heartbeat. The baby have some tone on it. Yes, we are happy, but the baby is born flat, pale. Baby born through antepartum hemorrhage. There is no heartbeat. This baby needs to have resuscitation very quickly. But in preterm baby, preferable conditions, we try to deliver as much as we can optimal cord management. Okay, let's speak about normothermia. What is normothermia actually? So in babies less than 34 weeks, we try and keep our temperature between 36.5 to 37.5. So this is the normothermia, normal temperature for this baby. Why do we do that? Because for each 1 degree centigrade drop in temperature, there is increased mortality of 28. So this is something that we can manipulate. So this is a percent of this that we can prevent by just providing good temperature. So how can we do that? The temperature is kept all through the process of delivery and transfer and admitting the baby. So environment preparation, okay, your environment temperature in the area where the baby is born. You have to make sure that this is not done by you, but it's done by all the neonatal team and the ops team together. We make sure that, for example, theaters, they will have optimal temperature. Okay, preventing heat loss by convection, conduction, radiation. Make sure there's no window open, or if there is, you think there is air coming from somewhere, you should raise the issue about this. Team preparation, communication within the team, okay, delayed cord clamping and applying a plastic bag once the baby has been born, and then your environment preparation. When we spoke about the radiant heaters, you should put them to the full, to the maximum. You should have your hats and plastic bags and your towels. That's the importance of these things. And then continuous temperature monitoring. Whenever, doing resuscitation, try, make sure that, okay, the temperature is okay, because with every drop in temperature, you're having 28% of losing this baby, okay? During stabilization, temperature during delayed cord clamping, your bag is there, okay? Continuous temperature monitoring, okay? Humidified gas, because of that, we said we're going to use the RPAP because it provides humidified gas. Document your temperature all through your processes. Transfer, make sure when you're transferring the baby is well covered. The baby has his nest around him. When you're transferring the baby in the resuscitator, make sure that all the sides of the resuscitators are up. Make sure that there is no air on the way. Optimal timing, adequate. Make sure that your resuscitator have adequate supply of power so your heat will not go away. Continuous temperature monitoring during transferring the baby, maintaining temperature again when the baby is out for cuddles, and humidified gas again during admission. Make sure again once the baby is up to the neonatal unit, you're taking the temperature. Timing of your procedure, timing of your the timing of removal of the plastic bag, and make sure when you do your procedures, that you are keeping the temperature under control. Okay. And the last part of this is early maternal breast milk, colostrum. Of course, as pediatrician, we all advocate for breast milk. It's the most beneficial, substance drug for preterm baby. So perinatal core element that support optimization of early maternal breast milk. You have to speak to mom before delivery, and that we need colostrum as early as possible. You can, make decision with your breastfeeding coordinator. She can help speaking, or your midwife. She can help speaking with the mom. Okay. Parents as equal partner in their baby care. You have to speak to them. Okay. Antenatal education, educate family about the value of maternal breast milk in prematurity and its importance. Initiation of expression soon after birth, within 2 hours, and the midwife will be one of the core parts in this, speaking to mom, helping her, providing her with the small syringe. Early colostrum administration for baby, ideally within 6 hours of birth, always within the first 24 hours. That's the first enteral feeding to be given to baby whenever possible, and early and regular parental physical contact with the baby. That will help the mother produce her milk. So this is, I'll just go back to the first one. I hope what I have said have explained all that, and I think you already have the idea about perinatal optimization for preterm baby. So I'll just recap again. It's a process done by the obstetric team and the neonatal team joint. So it's a joint care between both of us. We need to counsel the parents all through this process. The parents should be informed and should know what's going to happen for them and for the baby. It starts by the obstetric team by predicting the birth history, fetal fibronectin, cervical cerclage, and then antenatal optimization by the place of birth, whenever possible, in neutral transfer, as we said, administering antenatal steroid and magnesium and antibiotic. We knew when and why we're giving them and at what time we're giving them. And then peripartum optimization, we knew about optimal cord management, normothermia, and breast milk. So keep all this at the back of your mind when you're going to attend a preterm delivery. Okay. The other thing, I chose to speak about preterm delivery and hypoxic ischemic encephalopathy because your intervention matters. They are worth. So as early as you intervene with these babies in this situation, the outcome is good. So I will speak about hypoxic ischemic encephalopathy and the TOBI criteria. Would someone be positive and tell me about what is hypoxic ischemic encephalopathy and the TOBI criteria, if you have been working in a neonatal unit? Okay. Okay, hypoxic ischemic encephalopathy and the TOBI criteria. So what is hypoxic ischemic encephalopathy? As you see, it's hypoxia causing ischemia in the brain. So it's known as HIE. It's an acute brain dysfunction following critical lack of cerebral blood flow and oxygen delivery. So infants with HIE are often very sick babies with multi-organ failure requiring intensive care. These are the babies who, will be admitted to NICU immediately. And the treatment of hypoxic ischemic encephalopathy is therapeutic hypothermia. That means applying hypothermia. Without therapeutic hypothermia, the risk of death of severe handicap in a survivor of moderate or severe HI is approximately 25% and 75% respectively, so a high mortality. Children with and without motor impairment have lower cognitive scores, and they have a long-term follow-up, poor scholastic achievement, and often need educational support. So the outcome is really grim and bad. So early intervention is good. Perinatal hypoxia and perinatal hypoxic ischemia thus can create a major burden on the individual, the family, and the society, and this is something can be prevented. So let's just a quick go through this. So criteria for cooling: who are the babies who need cooling? Because this will be done as early as possible from delivery time of this baby. He had an ischemic insult, so I need to intervene. Any baby with gestation age more than 36 weeks, any baby less than 6 hours, and moderate or severe HIE. So sometimes we don't cool, but why? There are some reasons not to consider cooling. Cannot be started within 6 hours, birth weight less than 2 kilos, surgery, a baby with, a congenital abnormality who needs intervention, for example, in rectal malformation, needs fistula, any baby who needs intervention within the first 3 days, major congenital abnormality, severe clinical coagulopathy, death appears inevitable in perforated anus. So these are the babies that we don't cool. So there are criteria for this is the criteria for cooling. Let's see what is our TOBI criteria. So we have criteria A and criteria B. Evidence of peripartum hypoxia or ischemia, at least one of these. APGAR score less than 5 at 10 minutes. Because of that, I wanted to speak of that because we started with attending the delivery. So at time of delivery, you have a very low APGAR score at 10 minutes. That's the time of your intervention. You're not going to wait. Continued need of resuscitation, including intubation, LMA or mask ventilation at 10 minutes. Acidosis at your blood gases. Because of that, we said we need our blood gases. Any pH less than 7, cord blood gases less than 7, or a base deficit more than 60 millimole. That's on a cord or a baby gas, within the first minute of birth. So the baby is meeting criteria A. And criteria B is when you examine the baby, seizures or moderate to severe encephalopathy. So these baby will present it with altered state of consciousness, lethargy, stupor, coma. The baby is not responsive, lying flat, okay? And at least one of these, the baby is hypotonic, abnormal primitive reflexes, absent or wake suck, or there is no moral reflex or clinical seizures on the baby. So these baby whom we start calling immediately. I just want to speak about this. I don't want to go into the depths of it because it's a very big topic. I just spoke about this just to know from the beginning, from delivery time, what's happening here. What do I need to do? These baby need urgent attention. These babies need to go up to the unit and we start cooling. And cooling is either passive or active cooling. Okay, we attended the delivery. We knew what to do when going down for a delivery. We knew how to prepare our equipments. We knew that which babies need other part of the team. And then this baby is going to be delivered from the delivery, this baby is going to be transferred from the delivery suite to the NICU unit. So what you need to take care of while you're delivering the baby: ventilation. Is the baby needing CPAP? Is the baby needing ventilation? Okay. Oxygen requirement, respiratory support. You need to make sure that your ventilator has enough power and enough oxygen supply. while transferring the baby. You need to prevent your hypothermia, mainly hypothermia, hypoglycemia. Whenever you go upstairs, you immediately take your blood BM and make sure the baby is not hypoglycemic, especially the preterm and the extreme low birth weight baby and the sick babies. Okay, before transferring the baby, whenever the baby is born and problems are arising and this baby needs resuscitation, immediately call your unit. Immediately. Sometimes there will be a plan. Sometimes the unit know this baby is born, have problems, and we know about the baby, and they will try, make themselves ready for the baby. But sometimes you go down for a term baby who doesn't have complication but had an asphyxia, perinatal insult, asphyxia, perinatal insult. Okay, and nobody's anticipating that this baby will need to go up to the unit. So what are you going to do? As things are, going on, you call your unit. Oh, this baby's sick. I think he needs to come up, and the situation is that, and keep updating the unit. So call the unit in advance. Make sure they're ready for the baby. Tell the nursing staff about the baby's situation and what you need for the baby. Does he need CPAP? Does he need ventilator, high flow? Probably I will need a UVC and UAC. So things need to be prepared. Please don't forget to ask about your risk factors for sepsis, because if this baby is septic, you need to start your antibiotics as soon as possible within the first hour. Of course, things need to be, dynamic, and you need to prioritize things. You need to put a line, take bloods, a peripheral line, but as early as you can, take the blood culture and start your antibiotics and fluid. Okay, make sure your resuscitation has full oxygen tanks and sufficient battery, as I said. Involve the family and let the mom have skin to skin time before transferring the baby. This is very important, guys. Whenever things are evolving, you speak to the parents, to dad, to mom, tell them the situation one by one. Be honest, please. Don't keep things, don't hide things. See, as early as the parent are involved, they will anticipate, and they will know, and they will understand. If the baby is born with anorectal malformation or ambiguous genitalia, and you just covered it and said, okay, yeah, baby's fine, it's good, but you didn't tell them, and they are anticipating a boy or a girl, and after you admit the baby and up after a couple of hours, and then you're telling them, oh, we don't know the sex of the baby, this is a shock for them. So please always communicate with the parents. Don't forget to admit the baby on the Badger system. Okay, this is a must here. Any baby who's admitted to the NICU, HDU, should be admitted, or SCIVU should be admitted on the Badger system in your unit. Okay. Okay, so
Before we move on, we
yeah.
got some questions in the chat. So Ahmed asked about magnesium. I'm not sure if he got the answers before. And Aminat, she asked about why we do therapeutic hypothermia rather than keeping them warmer. So there is some talk about the metabolics and things, but we are waiting for your
Yes. So what happens is in the ischemic HIE, there is an ischemic insult. Okay, and there is ischemic insult. Okay, and when you keep the temperature of the baby down, you will prevent further insult to the brain. So that's the theory of therapeutic hypothermia. If we keep the baby warm and the blood is circulating as it is, there is more damage to the brain. So this is just in a nutshell, very, 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 very brief talk about this. But I promise you guys, we are trying to make a neonatal series. We'll be talking about all of these topics in details. Again, keeping the temperature low will prevent further insult. So that's the main idea about it. I hope I give you this. This is enough for you at the moment. Magnesium, Ahmed, I think we spoke about magnesium. It as we say, it reduced cerebral palsy by 30%. I actually don't know the specific how does it work. I need to go and know myself, but maybe in other workshops we will speak about that. It's a good question, actually. And what other question, Ilham? Okay. Any other question before going forward? Having my coffee. Okay. Okay. You delivered the baby. You anticipated the problems with the baby. You transferred the baby to the unit, and it's time to take proper history. So, of course, when you go down, you should take, your basic history, gestational age of the baby. Is there any problems? Is there any risk factors for sepsis? Is there any, the anomaly scans, did they say anything? Does the baby have a cardiac problem that, cardiology need to be involved early? Is it a congenital heart disease that is that needs to be PDA dependent? That means you need to keep the duct open, so give prostein as early as possible. What is it? What is the anomaly scan saying to you, and what plan has been put for this baby antenatally before he's going to be delivered? So this is a very important parts of your history when you're going down to delivery. Then, of course, your CTG. Is there any abnormality for the CTG? Is there any PROM, maternal temperature? Did she had antibiotic? And the liquor, is it meconium stained liquor? Is there any bleeding at the moment? So these are very important history. Is the mom taking any sort of medication that you need to be aware of? Labetalol, the baby might be hypoglycemic, maybe prone to hypoglycemia, sorry. Is she a mother with diabetes? The baby might be big or maybe small. Okay, so there are bits and parts of the history that you need to know as early as possible. And then when you admit the baby, you need to have a proper detailed history. So what are the proper detailed history in neonatology? So you need your age, minutes, hours, days. Age in minutes, that's when you see the baby down and then you admit him. For example, you've seen a baby in the postnatal ward who's 1 day old or 2 days old, and the midwife discovered there is some abnormality in the antenatal scans, or the mom has a congenital disease that may affect the baby, or there is a family history of certain disease. So you need to know about this baby and take proper history and examination. So take your age. What's the age right now for this baby? And I would like for myself, say, for example, age and date of birth. So whenever anyone is going to review my notes, he knows the date of birth rather than just flicking over the notes. Your gestational age and corrected gestational age is very important. Is it a singleton or multiple pregnancy? Is it diamniotic dichorionic or monoamniotic dichorionic? Twins, triplets. Recently, we have very lovely 3 triplets. So you need to document how many babies, the pregnancies is singleton or multiple, okay? And then you go to your birth history. And of course, we have covered the birth bit, but for example, you are seeing a baby in the postnatal, you haven't been in the birth history, you go and see the notes or ask your midwife what happened, or ask anyone of your team what happened. So event before birth, for example, PROM, maternal temperature, abnormal CTG, bradytachy's, medication during labor, for example, have been mom given morphine, Ventolin. Okay, is labor spontaneous or induced? Type of labor, is it a normal vaginal delivery, assisted by vaginal delivery? You will be maybe called for a baby who has a head swelling, but it's actually the baby has been delivered by a forceps, okay, or a baby has been delivered by a multiple trials of forceps or a ventouse delivery and has a subgleal hemorrhage. Emergency C-section, elective C-section, okay, has delayed cord clamping been done for this baby? For how long? Any history of resuscitation, what has been done for this baby? What type of resuscitation? Do you need just inflation breath, ventilation breath, CPAP? Has the baby been intubated and ventilated? Vitamin K is very important, guys. Did the baby have vitamin K? Is it oral or IM? Of course, we are preventing hemorrhagic disease of the newborn. birth weight of the baby. Is it a large for gestational age, small for gestational age, as a normal weight baby? You know, every category has its own problems. But large and small, they share the same risk of, you know, hypoglycemia, and hypoglycemia is fatal and has long-term effects on the cognition of the baby. So every piece of information is important, guys. Okay. Antenatal history is very important. Events during pregnancy. Okay, what was the last menstrual period and expected date of delivery? It just give you, you know, is it an accurate, you know, calculation of the gestational age, or there is some discrepancy? Type of conception, is it spontaneous or assisted? And for example, you may be faced sometimes with pre-genetic diagnosis. Have pre-genetic diagnosis been? There is sometimes some families will have a background of ongoing baby losses, fetal losses. There is a genetic problem, and this baby, it seems like there is a pre-genetic diagnosis, and this baby, just to know that this baby doesn't have complication, or does he have the same gene? So what is anticipated for this baby? Anomaly scans, any abnormality, involvement and plan of care for fetal medicine. Okay, follow-up scans and biophysical profile, fetal well-being. Is the baby growing well, or he's, you know, dropping his centiles, or he's not growing well? So this baby needs attention. Diseases during pregnancy. Did the mom have DGM, gestational diabetes, pregnancy-induced hypertension, antepartum hemorrhage, or any other disease, or any other, you know, medical background or inherited problems? Okay, and then screening investigation. In UK, there is screening investigation for any pregnant lady, serology and infectious diseases, HIV, hepatitis, rubella, syphilis, gonorrhea, chlamydia, and UTI. All of this, you'll find it in the maternal notes. So you have to have the habit of flicking through the maternal notes to know, or ask your midwife if you didn't know. But eventually, you know, you will get used. At the beginning, it was difficult for me to find all of this information because the maternal notes are really huge and big, but you need to know where to find these information, because they are very important. For example, HIV, HIV, a lady who need her baby needs BCG, you need to know about HIV and hepatitis. It's very important. And then of course, GBS. Is the mom GBS positive, negative, or unknown? Because there are certain guidelines for babies born to mom with GBS positive. Blood grouping and antibodies, anticipating if there is, the mom is rhesus negative, baby is rhesus positive, does he, you know, or ABO incompatibility. So each part of your history has its effect on its baby if you know it from early. Medication during pregnancy, again, steroid, magnesium, sulfate, insulin, labetalol, antipsychotic, opioid use. These are all affect the babies. For example, as we said, steroid and magnesium sulfate as part of the perinatal perinatal optimization pathway. Insulin, mom is on insulin. She's on she's a GDM mom on insulin. Any mom who have diabetes, her baby is prone to hypoglycemia. Again, mom who's on labetalol, again, babies are prone to hypoglycemia. Antipsychotic, opioid, do this baby need to be on the NAS scoring system? So everything matters. Maternal history, your mom's age, how old is the mom? Okay, mom's obstetrical history, parity. This is first, second, third, you know, pregnancy, and then any fetal or neonatal losses. Does she have children now? How many children does she have? Their ages? Do they have any congenital abnormality? Because that will affect your baby. You're screening for the baby. A mom with a 3 years old child who has developmental hip dysplasia, this child needs to be taken care of. So everything matters. Maternal diseases, if there is inherited condition, as we said earlier, do we need to take action? For example, some mothers with hematological diseases will have been seen by hematology, and there is a plan from the hematology unit for this baby, or a mom with a congenital heart disease. There is a plan, or a mom with, you know, you need to know about every piece of information matters for the baby. And then we will go to our clinical examination. Of course, neonatal examinations a little bit different from pediatrics, because you need to engage your eyes first. Look at the baby. Look at the baby, how he's positioning. And it's a tip to toe examination. Don't miss a part. Look at your baby while lying. What posture is the baby taking? Is it a flexed posture, good tone? Is the baby moving? Is the baby, responsive when you touch him? Okay. The general appearance of the baby. Is the baby alert, active? You will find some babies are really alert and active, and you will find some babies who are sleepy. But when you wake them, yes, they are alert, they're active, their posture are good. Make sure you check your neonatal reflexes, because when we speak about CNS examination in pediatric age group, CNS examination in neonate is the primitive reflexes, okay? Their motor reflexes is bilateral, equal, their sucking reflex, their stepping reflex. And of course, there is a lot of other primitive neonatal reflexes like parachute, and there's a lot. You have to make sure that the neonatal reflexes are fine. That means your baby neurologically is fine, of course, and he's alert and active. Your head. Look at your head. Is their head swelling? Okay. Does the head look normal? Your anterior fontanelle, your posterior fontanelle. Okay. Look at your baby's face. I always lift the baby up and introduce myself to the baby, say, hi, baby, how are you? As if I'm speaking to the baby. Look at the eyes of the baby. Look at the nose, the mouth, the general contour of the face. Look, is the low set ears. Some of the junior doctor would always ask, or even the midwives, the new midwives or the new trainee, how can we know that? Yes, I know it's a little bit difficult thing, but by time you will quickly grasp a low set ear. So what you do, it's an imaginary line. It's not something, very accurate. It's something that just, oh, this baby might have dysmorphic features, so he needs that and that and that. So how can we know dysmorphic features or low set ears? So the low set, you draw an imaginary line between the inner canthus of the eye and the outer part, and it should meet at the back of the head at the occiput. So if your ears are falling below this line, so these are low set ears. And then look at the ears. Are there normal eyes? Look at the eyes, sorry. Are they normal looking eyes? Shiny eyes, the eyes are jaundiced. Everything matters. Okay. And don't forget your hairline, low-lying hairlines with abnormal neck or like that. This may be a dysmorphic feature to look at the hands, the palms, the arms. Palmar cleats are very important. Look, do they have extra finger, losing finger, abnormal shaped hand? Of course, your chest. Look at the work of breathing. Is the baby breathing fast? Equal air entry, no air entry. Your cardiovascular is very important. Do you listen to your heart sounds? Is there a murmur? And of course, to your pre and postductal sats, if you have a murmur, and feel your femorals. And if you feel that the femorals are not, good, or there's discrepancy in your pre and postductal, so you have to do blood pressures, right upper limb and your lower limb blood pressure. So these are all things that are important in the neonate. Abdominal examination. Is the abdominal wall intact? Any defect on it? Soft, not tender. Bowel sounds positive. Any organomegaly? Hips, legs, and feet. Genitalia. Boy or girl, or there is ambiguous genitalia. And do not forget, please, to look at the anus and the back, because there will be a couple of cases, or there has been a couple of cases where baby has pooed, okay, and it's assumed that he has an anus in place, and actually there is no anus. So please open your nappies, wipe the poo, and make sure you've seen the anal opening. It's there and it's in normal position, and make sure the genitalia is a boy, testes are down, a female genitalia. And skin, of course, don't forget your skin, skin rashes, bruises. Babies, you will have a lot of bruises in the babies, because some babies are born through, assisted delivery, forceps, ventouse. I feel sorry sometimes for the babies. But you need to document all of that in your body map. So it's a holistic, approach in clinical examination. Look at the baby from the front, look at the baby from the back, take everything out, nappies, clothes, everything out, and look at your baby top to bottom, okay? There are a couple of things I want to emphasize, as I a little bit suffered from them myself. Blood gases and interpretation. You need to know about your blood gases, respiratory acidosis, metabolic acidosis, your pHs, and compensation and non-compensation and base excess. So I advise every one of you to have to go and look for books or references or anything to read about blood gases. But you will learn through your work. But it's better that you know how to interpret a baby on a ventilator, and how to know that he's having respiratory acidosis, he's having metabolic acidosis, because your approach will be different. A baby having respiratory acidosis, that means he's retaining his CO2, so you need to adjust your ventilatory settings. A baby is having metabolic acidosis, maybe he needs a boluses, or maybe he's developing sepsis, or something is wrong with this baby. So you need to know your interpretation for blood gases. Fluid requirements and fluid balances. You need to know your fluid requirements for your babies. Is it a term baby? We start with 60%. We start with 60 ml per kilo per day for a term baby, and preterm baby you start with 80 mils per kilo per day. So you need to know, and you need to know how you're going to advance. Fluid requirements is for both for the sick babies and the healthier babies. Sometimes you will be faced in the postnatal ward. There is a baby who didn't pass urine, okay, but there's no problems in the antenatal scan, but the baby is approaching 24 hours, not passing urine. He's a breastfed baby, so probably he's not taking much. So calculate your fluid balance for the feeding requirement for this baby, and make sure he's taking his requirement. So this is something that you have to have ready in your mobile according your trust guidelines. And then know your electrolyte balance and requirement, how to calculate your sodium, what's the normal sodium and potassium, how to calculate your deficits, and how to treat a baby with hypernatremia or hyperkalemia. This is a very important part of babies' management, because they are very sick, very vulnerable population. Okay. Any questions? Anyone want to say something?
Yes, Rod. Actually, there is a question about difficulties in feeling femoral pulses. Do you have any tips for that?
Yes.
Please.
Yes. I appreciate this question. Yes. Sometimes it's really, really difficult to find the femoral pulses. So what I will say, take off your nappy. If you have, some babies are big babies, strong. Once you touch them, you will feel the pulses there. And as you go through your, work and rotation, you will be very expert. Your fingers will be like, will catch them very quickly. But what you need to do, take off your nappy, okay? Try to ask the midwife or someone to help you. Give a baby sucrose, make the baby suck, relax. Don't put the baby in tension. I mean, don't, overflex the legs, or just let the baby relax and put your finger, take your time and press the groin area, and try to move gently around this area until you find your pulses. Sometimes they are there, but you're just missing them because the baby is fiddly, moving a lot. Big baby, obese baby, but you have to make sure that you felt your femoral pulses. Any other question?
Yes, if you have any template for electrolytes for calculations, I think it should be like trust-based or...
Yes, exactly. That's a trust-based thing. You have to go. The thing in UK, it's always trust-based. That's one of the things I found difficult when I came here, because where I come from, it's your references books, it's your, general information that everyone knows as, a medical student or a medical doctor. But in UK, you have to stick to your trust guidelines. So for sodium, there is if you did your one of the most important things also, about your hyponatremia and hypernatremia. This is something maybe here in North Island particularly we need to do the BMJ hyponatremia course to know how to manage hyponatremia, but search your trust guidelines. There always will be trust guidelines for this. Any other question, Ilham?
Nothing in the chat so far. Yep.
Okay, let's go on. Okay, I would like to listen from you guys here. How do you survive your duties? What do you do? And how do you survive your nights? I want to listen from you. Would someone like to tell me? Okay, I'm going to pick myself. Whom do we have? Sorry. I can't see you guys. Lujain Osman. Hi, Lujain. Okay.
Hi.
Hello, hi, Lujain. How are you?
Good, thank you.
Good. Where are you joining us from?
I'm a Paediatric Trainee ST2 East Midland.
Good.
Leicester. Yeah.
Good, good. Have you been working in a neonatal unit?
No, the next shift will be LRI unit. So that,
Good, good.
I feel this. I mean, in the good time.
Good. You're welcome. So, tell me what do you do during your duties? Your day duties, night duties?
I mean, the day duty is for me is more better than the night.
Yes.
I mean, speaking about the general bits, because I didn't do unit before.
Yeah.
Because in day we can have the round. We will. Yeah. I mean, we know more about the patient. But at night we just come and have some jobs to do.
Exactly.
So yeah.
Yeah. Exactly. Anyone else want to add something? I would really like to. I want this to be interactive and, you know, share our experience because my experience is different. I want to have, you know, a glimpse of other experiences. Who want to let me know what they do? Can't see you all. Don't know why. Not iTech today. Ifa Oba. Ifa. Is it Ifa Oba? Hello.
Where is this one? I can't see the hand raised, Rawda.
Is there a hand raised?
No. I couldn't see that.
Okay. I would really like to listen to you guys.
I think Ahmed is tertiary one, but he is on duty today, so he's not able to open the mic.
Okay.
Sarah, are you here? I think Sarah as well is working.
Raji Safia. Is that right? I'm just picking names. Raji? Mayada Dawood? Okay, guys. So it's more or less the same. I just want you to be positive. Stay positive. Duties in NICU are sometimes really tough. They're not easy. You need to be coming well prepared, okay, for your duty. Stay positive and know you are learning. You are pediatric trainee. I'm speaking about level 1 trainees. You are someone who come here to learn. So be positive. You know, always try to ask your seniors around you. And one of the important things in NICU that will be a little bit different from the pediatric wards is that you are washing your hand constantly, guys. You are washing your hand all through the day. And I have been suffering from this because I had like, you know, eczema, dry hands. Even till today, my hands feel like, you know, very rough. So what I advise you, you need to have your Vaseline, your cream in your pocket. Always don't forget it. Leave it there, you know, after you finish. And sometimes in NICUs, you will find, in our NICU, you will find, you know, creams around. You know, the nursing staff will put creams whenever you feel your hands are dry. You really need to take care of your hands, because you're going to work with them, and if you got infected by eczema, if you got eczema and got infected, that's an occupational hazard. So take care of your hands. Communication guys are two-way direction. Okay, you will be calling other departments asking for help and advice. You always need to use your SPAR. Okay, and don't forget to introduce yourself and say what's your role. So you speak about the situation of the patient, the background, the assessment of the patient, and what do you want from the recommendation. Why are you calling this patient? So like a precise, concise history. For example, if you have a cardiac patient and you need to call the cardiac team, this is baby X, gestational age, say the most important relevant part of the history. Okay, baby at the moment is on room air, needing oxygen. You know, there is discrepancy between the pre and postductal SATs. Okay, and we started that, and we're looking for advice, or looking that you need to come and see the baby, please come and see the baby urgently, or like that. Or for example, even booking an ultrasound, and you need it to be done as early as possible for a very sick baby. Calling the radiology department. I am ex-doctor calling you from NICU. I'm taking care of baby. I have requested an X-ray or an abdominal ultrasound or a barium swallow or a barium meal or whatever. We suspect that this baby have X syndrome or X condition. We would like you to do it as early as possible. When can you do it? Can you give us time? Maybe today, maybe tomorrow, or call us tomorrow, or you know, they will call you back. So this is the way you have to give a full you have to give, you know, a concise, clear message to the other part, and you will be receiving the message sometimes from ID, for example, infectious disease, telling you that the blood culture showed that and that. We think we need to give this antibiotic. If you have a question you want, ask, please. Don't take things as it is. Ask in a very polite way, gentle way. Why are we doing that? What's the rationale of giving this and like that? Because when you deliver the message to your neonatal team, they will expect a full message. Sometimes people will be busy, they will just give you the message, they don't give you the rationale, but you need to know why we are doing that. Okay, and then please involve all team members. As I told you from the beginning, ask your nutritionist, pharmacist, nurses, ask everyone around you about anything you don't know. And this puzzle, it has bits and pieces. Everyone will give you a piece of it. So you'll have a full picture at the end of the day or by the end of your rotation. Please use your calculators and apps, and I will show you now good sources, things that I have been using personally, and probably some people have better things than me. Please take care of yourself. Really take care of yourself. Your water, your food, your caffeine for you and for the babies. Babies need caffeine to breathe, and you need caffeine to work. So if you're a caffeine person, you know, take your break, take your time with your tea, coffee, use your breaks to chill out, get involved with the team, you know, chit chat, drink, eat. Okay, this is very important during a heavy duty. And please don't please don't be afraid of asking again, and stay positive. Always stay positive. Even if you make a mistake, please reflect on it. Ask your seniors what was wrong, what mistake did I do, and how can I prevent it, and what's a better way to deal with this. And I really found that doing CBDs, mini kicks, and reflection with your consultants, with your senior regs are really useful, because sometimes if you go back and read, there are things between the lines that you can't get. You get them from an experienced person who tell you, okay, no, you need to do that and that and that and that. because this is the proper way. Yes, the book says that, but actually the interpretation of this is that and that and that. So as a pediatric trainee in a NICU rotation, please make sure you do your TOBS, you make sure you do your reflection, your CBDs, your mini kicks and reflection. And you have to make, you have to make use of yourself for yourself. I mean, if you've seen a baby with respiratory distress, this is a very good thing for CBD. Do your CBD, speak about ventilators, speak to the consultant or your colleagues. How can I do the ventilators? A case in the postnatal ward, a baby who has been collapsed or a strange case, do your mini kicks, your CBD with it. And there is one topic that is really not easy to speak about. I'm not, an expert in it. It's ventilators. Ventilators. Ask, 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 and ask. Don't never be shy. Ask for the ventilatory setting. You did a blood gas and it shows like that, and your reg is changing the ventilator setting. Oh, why did he change the ventilator setting? Ask him politely for an educational point of view. I need to know. The blood gas show, for example, metabolic shows respiratory acidosis and your CO2 is high. What did you do on the PRVC? What did you do on the high frequency oscillatory ventilation? CPAP, why are we going up in the pressure? Why are we going low in the pressure? So please ask. You're allowed to ask and learn in this setting. And then finally, your tools and apps. Of course, NewMate. You need your NewMate app. That's an app where help you calculate your UAC length, UVC length, will help you choose your the size of the E-tube and the length of the E-tube and gives you a lot of other information, your growth charts, because of course, maybe I missed talking about that. When you're doing your ward round, part of the baby well-being is that the baby is growing. He's growing his head circumference and his weight. You need to know about that, and you need to plot it. Of course, in the Badger system, it will be plotted already in the growth charts, but a baby in postnatal, you need your growth charts. I'm not sure nowadays if the growth charts are available, because I tried to download it from one of my friends and I couldn't. But that's the app I'm using, and I have it in my mobile now. Billy app is very important because neonatal jaundice is one of the very frequent clinical scenarios that will be faced in NICU, in wherever, in postnatal, in HDU, SCIBU, and NICU. You need to know what is the safest. It will show you the graph where you need to start your phototherapy, where you are approaching the exchange transfusion. It's a very big topic. Hopefully, we'll have one day a speaker to speak about neonatal jaundice. And then you have your KP calculator, Kaiser Permanence Calculator. So for you who don't know about this is a calculator where you calculate the possibility of sepsis for the babies. You have certain inputs. You have your early onset incidence. You will put it in the calculator. You will put your gestational age, weeks and days, and you put the maximum maternal temperature in Celsius degrees, and your PROM, how many hours, and then the maternal situation, the maternal background. Does she have GBS? Is it known, not known, positive or negative? And then when did she have her antibiotic? You will have four categories to put here. A mom who had her antibiotics more than 4 hours or less than 2 hours, and in between. Of course, less than 2 hours, that means it's not efficient as 4 hours. And then the calculator will give you the risk of at birth of early onset sepsis. That's the risk. And then there is the clinical evaluation, where you have well-appearing baby, equivocal, and clinical illness. I didn't put the rest of, there is a rest of Performa. where you see what is equivocal, what is a well baby, what is a critically ill baby. For example, a baby who needs resuscitation, ongoing oxygen, ongoing respiratory support, and the FiO2. That's a critically ill baby. For example, a baby who is having tachycardia, tachypnea for more than 4 hours, or both of them less than 2 hours, is equivocal. So you need to take your risk factors, and then you need to assess your baby and put all of that in your calculator, and it will give you a clear cut what to do. This baby needs to be screened and covered. This baby, you know, doesn't need screen and cover, and will give you the frequency of the observation for the baby. Of course, I think every trust has the regional guideline. North Isle has changed a little bit in this guideline. For example, if equivocal, we will screen and cover the baby. If the Kaiser permanence calculation said screen and cover, or said empirical antibiotic, then we will screen, take bloods, and screen and cover the baby. And there is some modification in the ways we do our observation for the baby. And guys, of course, nowadays we are in the era of social media and YouTube channels and Google, you know, so there are good resources. And these are two of the good resources that I found that I'm using personally. Maybe someone else has something else. So we have at the bottom here, Tala Talks NICU. This is an American YouTube channel. Tala, she's a NICU consultant. She has very wonderful talks. You can go and scroll through topics like, for example, persistent pulmonary hypertension. You want to know about that. You want to know about cord blood gases. You want to know about, so you go, and I will say subscribe and just watch. For you who didn't start their NICU rotation, you can go and look at this Tala Talks. And of course, New Sim, Royal Jubilee Maternal Hospital. That's my hospital where I work. This is the New Sim team in Belfast, and a big shout out to them, and a very thank you. They're doing an amazing job teaching us and helping us through our rotation. So they have very wonderful YouTube videos. They are working with the regional guidelines. So if you find it a little bit different, where are you working, like from where you work? So just bear in mind there is a difference in, you know, trust guidelines, but it gives you nice information if you want to know. So again, you will find a lot of things, how to do UVC, UAC, and it works through our regional guidelines again. It speaks about how do you do cranial ultrasound, lung ultrasound, and there is a lot, and it's an ongoing YouTube channel. Every day you will find something new. So I also advise you to subscribe to this channel. And that's it for today, guys. Any questions?
I think someone asked about the name of this calculator at the right upper corner.
Yes, so this is not an app. Unfortunately, it's called the Kaiser Permanence Calculator. So what I do, you go on your mobile phone, for example, go for KP calculator or Kaiser Permanence Neonatal Sepsis Calculator, and it will pop up to you. So what you do, you save it as, I save it as a screen desktop. I'll tell you something. It's just easy for me. It's not an application. But you can save it on your, let me see, what is it called? You just save it. It will be saved on your screen. And then what I do, I have like a folder where I put all my pediatric application and pediatric screen shortcuts. So it will be easy. And you really need this one on your phone because it's really important. It gives you, I think most of the trusts here in UK work with the Kaiser Permanence Calculator for neonatal sepsis. In the old days, there was the NHS, the NICE guidance for neonatal sepsis, but unfortunately, a lot of babies will be screened and covered. But this one will is limiting in a safe way the numbers of baby who has been screened and covered. So it's very important to have it on your phone. It's not an application, it's just you can do it as a shortcut on your phone. Any other questions?
Can't see anything from the chat.
Can you write the name again? It's let me see. It's Kaiser Permanence Calculator. I'll write it for you now. It's actually a tool developed by the American. It's permanent, sorry. I think it's a research center. It's adopted by the UK here, so it's really handy. Yeah. Oh, thank you very much, Mayada Dawood. Thank you, appreciate it. Any questions, guys? I really would like to listen to you guys. I feel I'm speaking to myself. Thank you for Ilham for moderating today.
Mine's all right.
I really like to listen from you guys.
If you got any questions.
Yeah, any question, any thoughts, we are planning to deliver, as I said, some neonatal series lectures. We're trying to recruit some consultant. It's not an easy job because this is something done on their free time, but we will try to deliver at least one lecture every month or every 6 weeks or even 2 monthly, but we will try to continue this series. And I would like to listen from you guys. What do you think you need to, what do you think is the important topics that you need to be taught on? We thought like we will take it as respiratory. We'll speak about respiratory distress syndrome, or a baby presenting with increased work of breathing, and then we'll speak about ventilators and blood gas, and then we thought we'll going through cardiovascular. We will speak about preterm babies and PDA, because this is one of the challenging things for premature babies, and then speak about neck and see, like, you know, the more like neonatal jaundice. So let me listen to you. I would really like to hear you.
So Rawda, some people interested in mechanical ventilators, and that's nice. We are arranging this very soon. Much. And if you recommend a neonatal cranial ultrasound, because there is a question in the chat about that.
Courses, I really don't know. We in the Belfast Trust, we do local courses, but there is, if you search, what I always do, I search, for example, cranial ultrasound, UK guidelines. There is a lot of resources, guys, on Google, if you search Google. So you will find, and of course, always try to look at the trust guidelines, the neonatal unit guidelines. So I can't pinpoint something specific. Like, for example, when I was looking at the cranial ultrasound or the lung ultrasound, I was searching and I found some useful guidelines, and always look at the updated guidelines or the, you know, the new guidelines, because, you know, science is really updating these days. Someone asked about blood gases.
Yeah, about respiratory support and adjustment with the different situations.
Yeah, I promise you, we have a speaker, just we are awaiting for timing when the speaker will tell us about his time. And we're planning the next lecture, hopefully, fingers crossed, for PDA, because I think this is one of the topics that are really, really challenging in preterm baby for you who worked in neonatal units. Okay, any other questions?
Can I ask what is Liza?
Lisa, yes. So Lisa, it's less invasive surfactant administration. So what happened in the old days, we intubate the baby and give them surfactant, and actually the baby doesn't need the tube for this, especially for the preterm babies. They don't need the tube because we put the tube for respiratory support. But then there was a new way of giving surfactant. It's less invasive. It's a small catheter, like an NG tube catheter. So it's called the Lisa catheter. So you use this instead of the tube, and you administer the surfactant, and it's easy just to get it out. Yes, we will upload, hopefully, yes, this lecture to the BSAP-CH
Same
YouTube
like
channel.
Insure technique?
Yes, yes, yes.
Then what is LMA with the Lisa also?
Sorry, what is what? Just
LMA. Written with Lisa also.
Oh, yes, laryngeal mask airway. This is our different airways. I also advise you guys go and know about your airways. You have to know there is different airways. There is laryngeal mask airway, there is oropharyngeal airways, and there is airways used in the neonatal period, and the oropharyngeal airway also. So this is part of your NLS. So go please, from today, if you don't have an NLS, go and book your NLS. It's a very useful course. And what I found when I studied the NLS the first time, because I came from Sudan, we do neonatal resuscitation course, the neonatal resuscitation course, NRC. Think so? People who had it in Sudan. So it's a little bit different from
NRB?
NRB, yeah. So it's a little bit different from this. I was so confused when I when I did it the first time. It's really simplistic approach. This one is really simple. It has a very big book, but there is if you go on the resuscitation UK Resuscitation Council website and go and look for neonatal resuscitation, you will find a simplified version of the book. It's really useful, guys. It's really useful. Even if you didn't have your NLS, download it, keep it with you, study it, study it. This is your book. And then do your courses even after that if you didn't do it. But it speaks about how you go through the NLS. So NLS is like ABLS. It's basically what you do is airway, breathing, and circulation. You make sure that you are aerating the baby. You're delivering, opening the airways for the baby by delivering inflation, trying to inflate the lung and make sure there is chest rise. So if that's not happening, you're not having chest rise, that means your airways are blocked. So either you do a 2-person technique, and make sure that you're positioning the head of the baby okay, or make sure you are suctioning because the baby is born through thick meconium. So that means that the airway is blocked. You suction the airway, you clear the airway, you position, you do a 2-person technique and hold your mask in the correct way. And if you are doing it in the correct way, and if there is no blockage, you will see chest rise and your heart rate will be coming up. So that means that you are aerating the lung. Then either you go for ventilation breath. That means, if you are, if there is chest rise and your heart rate is going up, then you will go for providing ventilation breath if the baby is not breathing or not crying by himself. And if you're not getting chest rise, if your heart rate is not getting up and the baby is floppy and the color is not great, that means this baby needs to be intubated. That means the airway cannot be cleared. So this is a decision taken by your senior. This is when you need to call your senior. Please come down quickly. Don't play with these babies. But it's an extensive course. You will learn about approach to term babies, preterm babies, and I really, really advise you, please go and book your courses today. Okay, any other questions?
No, we can't see. Yeah, just 1 second.
Hi Ilham, I'm
Hey.
Aslam. Just to clarify,
Hey.
because you all are from tertiary centers, if you have experience of NAVA ventilation, this is neurologically assisted ventilation, or this focus scan, you know, I appreciate if you can consider lectures on that as well, because we don't have access to these things, because now we are moving forward toward these things. So if we can have some idea about this NAVA and focus scans, it will be really helpful, please.
Yes, yes, yes. I appreciate you speaking out. Thank you very much. Yes, we will try our best to cover the ventilation, like at all levels. The NIV-NAVA. I totally agree with you. I work in a tertiary center where we use NIV-NAVA, and I found it brain blowing. Like, it's an easy approach, but again, it's not easy. It's not something that we have been used to, and it uses different setting. But yes, I will try and promise you that we will deliver such lecture.
Thank you.
You're welcome.
Lovely to see you, Aslam. Thank you for joining us.
Okay, I think that's it. That's the end of it, guys. No one have any question or any comment? I hope it was useful today for you guys. And I just tried to make this as an introductory lecture for neonatology.
Yeah, thank you. Thank you for organizing this. I'm very happy, Ilham. You're doing very well.
Yeah. Thank you. Thank you very much. I'll stop sharing, guys, so I can see you. Yes. Yes. This is, as I told you, this is an introductory lecture. I just wanted to lay the ground for you guys who are going to work in a NICU unit or going to their neonatal rotation, next rotation, or the coming rotation, or coming, you know, at any time. So hopefully we'll continue with this series. I just wanted to make it simple. Sorry if I didn't answer all the questions in details, because these are very, very big topics. If we go in details, we'll not finish. Neonatology is a very big, big branch of pediatric medicine, has its own ways. The small babies are different from the big babies, and you have the very sick small babies, and you have the babies in the postnatal ward, and it's really, I don't want to say complicated, but it's really big, diverse branch of medicine. And again, please stay positive. Always ask your seniors. This is something that you're not judged, but not knowing it as a junior, okay? Because you are starting your neonatal training to know about babies. And maybe I'm an old-fashioned girl. I used to write everything. In the old days, I would write, but now my writing will be my reflection in the portfolio. So it will be there, so I can go and look, and so people knows that, oh, I'm reflecting on things. Okay, thank you very much, everyone, today for attending our lecture. I appreciate you attending today and supporting this. Ilham, thank you very much today.
Yeah, thank you indeed for having you today. It's really an inspiring topic, and I can see the interaction from the attendees. And thank you for joining on Saturday. It's your off days, and I know it's very hectic here. So please, a reminder for the feedback form, so you can enable us to improve. And if you got any ideas for the coming things, you can write down the things. And if you still have some queries, you can send it to us through the PSAP-CH email, and we would definitely send you back about the questions. If you got anything in your mind, any suggestions, it would be appreciated. And thank you again for joining us. and happy Eid.
Happy Eid. Yes, I just want to remind, please, the feedback form, has it been shared or what, Ilham?
Mohammed sent that. Yeah, Mohammed, if you can just resend it, please.
Yes, please. The way of saying thank you today, please fill the feedback form. We need to know, because we want to deliver more lectures. We need to know if this is good. Should we continue? What sort of topics you want? In which way do you want it? And we will appreciate if you can be, guys, interactive in the next coming sessions. So please fill the feedback form. Thank you very much for the people who done it. Okay, have a lovely rest of the day, people, and see you soon. Thank you, Ilham. Thank you, Muhammad. Muhammad Osman, who is our host here. Yeah. Thank you very much, Muhammad. Thank you very much, guys. Bye-bye. Bye.